Hey, welcome to The Explainer. Knee pain is one of those things you're going to see all the time, and the list of what could be wrong can feel, well, a little endless. So today, we're going to cut through all that noise and build a really clear, systematic way to think about knee pain, especially for trainees who are just starting out.
So here's how we're going to tackle this. We're going to walk through it just like you would with a real patient. We'll start with that initial challenge, when the patient first walks in. Then we'll get into our best diagnostic tools, map out the usual suspects, figure out when it's actually time to order tests, and then wrap up with how to manage these common problems.
All right, so let's just jump right in. Picture this. A patient walks in, says, "Doc, my knee hurts," and that's it. It can feel kind of overwhelming, right? Like, where do you even start? But I promise you, having a structured approach is your absolute best friend here. It's what turns that vague complaint into a clear diagnosis.
So where do you begin? And the answer isn't order an MRI. Not yet, anyway. The first step is to put on your detective hat. The most important clues, the ones that will lead you to the answer, are found right there with the patient. It all starts with a really good history and a focused physical exam. And I'm telling you, these two things, the history and the physical, are your absolute superpowers. Way before you even whisper the word imaging, a great history and physical exam can get you like 90% of the way to the right answer. Let's see how.
The patient's story is just packed with clues. So they tell you they were playing soccer, twisted, didn't hit anyone, and heard a pop. Your brain should immediately be screaming ACL. What about swelling that blows up within an hour or two? That points to what we call a hemarthrosis, which is just a fancy term for bleeding right into the joint space. A huge red flag for a big injury. Or if they mention locking or catching, now you're thinking it could be a meniscal tear. See, every question narrows it down.
Okay, so you've got some theories based on the story. How do you start confirming them? Well, the physical exam isn't just random poking around. It's all about a series of very specific moves, where each one is designed to stress and test a particular ligament or structure. Let's get into the heavy hitters for the major ligaments. And this, right here, is where the physical exam just proves its worth. I mean, look at this. Just look at that number for the Lachman test. A positive likelihood ratio of 42. That's huge. It means a positive test basically screams ACL tear. It's way, way more useful than the anterior drawer test, especially when the knee is all swollen and angry. Make the Lachman your go-to. And we can use that exact same systematic logic for the other big ligaments. The posterior drawer test checks the PCL. For the side ligaments, the collaterals, we use stress tests. A valgus stress, that's when you gently push the lower leg outward to stress the inside of the knee, that tests the MCL. And a varus stress is the opposite. You push the lower leg inward to test the outside of the knee, the LCL. It's a simple structure-by-structure check. So, what if you're thinking meniscus? Well, your goal with the exam is to try and recreate what the patient is feeling, that locking, catching, or pain. These tests, like the grind test, Thessaly, and McMurray, are all designed to do just that. You're trying to provoke that specific click or pain right over the joint line that tells you a tear is likely. All right, you've got your story, you've done your exam, you've got a ton of clues. Now it's time to play detective with geography. Seriously, just asking, point with one finger to where it hurts the most, can narrow things down like you wouldn't believe. It lets you map your potential diagnosis to very specific spots.
Okay, let's look at a classic head-to-head matchup, ACL tear versus a meniscal tear. And honestly, the biggest giveaway is often the swelling, or what we call the effusion. When you tear your ACL, you often tear a little artery with it, so the knee fills up with blood, fast and big. A meniscal tear, on the other hand, usually doesn't have a blood supply, so the swelling is slower and less dramatic. That one little detail is a huge clue.
So if the patient points right to the front, right on the kneecap, bam, your list of suspects gets way smaller. You're almost certainly dealing with the extensor mechanism. It's either an issue with how the kneecap is tracking, that's patellofemoral pain syndrome, or it's irritation in one of the tendons attached to it.
Okay, what if they point to the inside of the knee? The medial side. Well, now we've got a whole new lineup of the usual suspects. It could be a tear of the MCL, it could be an inflamed bursa, this tricky little spot called the pes anserine, or it could be good old-fashioned wear and tear arthritis. And this picture, it shows the location of pes anserine bursitis perfectly. See how it's not actually in the joint? It's a few centimeters below it, on the inside of the shin bone. This thing is a classic mimic, especially in runners or people with some arthritis. It fools a lot of people into thinking the problem is inside the joint, when it's actually not. And last but not least, what if the pain is on the outside of the knee, the lateral side? Well, you're in luck, because that list is pretty short.
For the most part, you're trying to decide between IT band syndrome, which is super common in runners, and an injury to the LCL. Okay, so you've built a really solid case. You have your main suspects lined up based on the story, the exam, and the location. So what's next? When do you actually pull the trigger on imaging or other tests? Let's talk about being smart with these tools. This is super important. Not every knee needs a picture. X-rays are your go-to if you're worried about a broken bone or really bad arthritis. And the MRI, here's the best way to think about it. It's not really a diagnostic tool, it's a surgical planning tool. You order it when you're pretty sure there's something torn inside that might need an operation. Okay, this is one of those rules you just have to burn into your brain. If you see or feel a big, squishy swelling right on top of the kneecap, prepatellar bursitis, you have to stick a needle in it and drain the fluid. Why? Because a septic or infected bursa is something you absolutely cannot miss. And the only way to know for sure is to look at the fluid. Okay, so we have our diagnosis. Now what? We have to actually treat the patient, right? The last piece of the puzzle is figuring out the right management plan, which usually comes down to two main paths: conservative care or sending them for surgery. This is a really high-yield point for ligament injuries. For an ACL tear, especially if your patient is young and wants to stay active, you're probably looking at surgery to get that stability back. But, and this is a big but, most of the time, PCL and MCL tears do great without an operation. They heal up beautifully with some good old-fashioned conservative care, like bracing and physical therapy. And what about that super common pain in the front of the knee, patellofemoral syndrome? Well, the evidence here is crystal clear. Ice and rest are nice for a day or two, but the absolute cornerstone of treatment is physical therapy. It's all about strengthening the muscles around the knee and hip, the quads, hamstrings, and especially the glutes to help the kneecap track properly again. All right, let's wrap this up with the key takeaways, the stuff you really need to remember. If you see a big, fast swelling, think ACL. The Lachman test is your best friend for diagnosing it. Most MCL and PCL tears get better without surgery. If you see that swelling on top of the kneecap, you have to aspirate it. And for pain in the front of the knee, the answer is almost always physical therapy.
And that leaves us with one last, really important question to keep in your mind. We've talked about all the common stuff, but you always have to be thinking about the dangerous things, the red flags. Because that hot, swollen, really painful joint, that could be septic arthritis. And that, my friends, is a true orthopedic emergency that you have to act on immediately. Always thinking about the worst case scenario is what keeps your patient safe.